Hey everyone, Samantha here. Thanks for joining us tonight. This is Trans IRL. Tonight we're going to be wrapping up this season's series of interviews with surgeons who support the transgender community. Although we will strive to have more surgeons on in the future, the COVID-19 pandemic offered us a rare opportunity to work these interviews into their very busy schedules. And Stephen and I are both thankful for this opportunity to share their stories and have them answer your questions. Speaking of Stephen, he's right here in the Trans IRL control room monitoring the chats tonight. So if you do have any questions for our guests, please make sure to submit them on YouTube, Facebook, or Twitch, and we'll try to get to as many as possible. It's going to be kind of a busy hour here. 3 quick notes before we bring our guest on tonight. Number one, conversation around any transition-related surgeries may be difficult, so please be aware if this conversation is something that may be difficult for you to listen to. We are going to be sharing some after-surgery results, nothing gory or anything like that, but just want to give a heads up that that is something we're going to talk about tonight. Number 2, our guest is joining us today without compensation, and no one associated with the show has been compensated by our guest. This conversation is presented as a casual conversation and not as medical advice or as a recommendation for any provider over others. And number 3, gender-affirming surgeries are not a requirement in transition. Each journey is unique, and no one is more or less valid than anyone else because of want of, access to, or completion of surgical procedures. Okay, that was a mouthful. Let's go ahead and get on with the show. Tonight's guest is a plastic surgeon and reconstructive surgeon who has focused her career on providing services to the transgender community. In her career, she's advanced surgical techniques, been a founding member of multiple transgender medical support centers, and provided training and support for other surgeons in the field. So tonight, I would like to welcome Dr. Sidhbh Gallagher to the show. Dr. Gallagher, welcome.
Hi, thanks for having me.
Yeah, absolutely. It's wonderful to have a chance to sit down and talk with you here tonight. I've been following your page for quite a while and have always been really impressed with your willingness to connect with the community very closely. I think that's very admirable.
Absolutely, thank you.
So let's start by allowing you a chance to talk a little bit about where you grew up and your family.
Okay. Well, so most people, it's a giveaway pretty quickly once I open my mouth that I'm not from the United States. I was born and raised in Ireland, and I actually didn't immigrate here until I was about 26. So I did medical school in Ireland, and I worked as an intern in Dublin. And while I feel like I got very good training there, I kind of felt like it was still an old boys school back in the day, so I really knew I wanted to be a surgeon, wanted to be a plastic surgeon for that. So for that reason, I picked up and moved to the United States. And my first stop was Philadelphia. That's where I did my general surgery training. And that really, Samantha's where I lost about 5 years of my life. I don't really remember much of Philadelphia because back then we used to work, 100-hour weeks, and it was general surgery, a lot of trauma, a lot of gunshot wounds, stabbings, things like that. So that was general surgery, and then I was very lucky to get into plastic and reconstructive surgery. So it's 5 years of general surgery, a further 3 years of plastic and reconstructive surgery in Indiana University in Indianapolis. And that's where I practiced for the first 5 years of my career as an attending as well, and really, where I began to focus on this work more and build a program there.
So let's talk about that a little bit. When did you know in your career that you wanted to start providing transgender affirming surgeries?
So plastic surgery is an awesome field because you get to use the artistic side of your brain, and you get to focus on form and function. And that was really what drew me to plastic surgery. But I guess what I understood, about 7 or 8 years ago when I began to become interested in this field, was that more than any other field, aesthetically pleasing surgery was so important, so it was really important to make the patient look good, to have it function well. And then on top of that, more so than just, let's say, cosmetic surgery, this is such a meaningful and important thing to the patient. So that was probably initially what drew me in. The surgeries are fascinating. You get to operate on all sorts of different anatomy, different parts of the body. But then really once I began to work with the community, I, fell in love with it, obviously, because you get such a buzz and such a high from being around somebody whose dream is coming true, and it's
Oh,
a
absolutely.
very privileged, position to be in. Yeah. So that's what hooked me. And, about 5 years ago, I really began to focus on that aspect of surgery, and here I am now.
So when you first started working with the community, what was the input you received from people who were coming to you for services? What gaps were you made aware of in trans-related care, and how did you set out to help close some of those gaps?
Right, right. Well, Indianapolis, it's the Midwest, not the most progressive place, and I was uh, probably the only surgeon. I certainly was 5 years ago. I was the only surgeon offering these surgeries. So I'll always be very grateful for the community who put their trust in me and were welcoming. And but it was very clear that services were limited at that time. Now, thankfully, some other providers to do hormone therapy, for example, were coming to the area, and things certainly improved within Indianapolis. But in a lot of the surrounding areas, and Illinois included, and certainly Kentucky, services were really lacking. And it was difficult for patients. Also, back then, it was very difficult to get anything covered through insurance. So there was a huge gap in care in the Midwest back then. And I would say even amongst medical providers, there was a lot of misunderstanding with the community. And, it was very difficult, for example, transitioning in the rural Midwest. A lot of my patients would routinely have to travel 250 miles plus, just to get their hormones. So, but I mean, the same still goes for today, unfortunately. There's really not many surgeons focused and trained in this work right now. Things are getting better, but a lot of patients have to travel. And now, even in Miami, a lot of my patients are from out of state.
Yeah, I think that's still something we face across the community, is that for, surgical support, there are still very few people who have put the time in to, be at the level where people feel comfortable working with them. So people will travel for surgeons. I mean, I've done it. I've traveled 6,000 miles to see a surgeon because that was where the surgeon was
Yeah,
that I trusted.
yeah,
But I
yeah,
think that's still definitely a part of the community, in that a lot of us have to travel to, meet
right.
with the surgeons or work with the surgeons we want to work with. I do want to talk
Yeah.
about when you actually first started the program there in Indiana. Did you face any difficulties, or was there any pushback when you had started originally?
Yeah. Well, Samantha, I tend to be a very naive person, and an eternal optimist. And I think, back then I thought everybody loves us, everybody can see what good work this is and how awesome the patients are. And to a certain extent, that was very true. I was actually quite surprised in Indiana, for example, in the surgical suite, the most of those staff didn't sign up to work with me. This was something that was put on them, or said, okay, we're doing gender affirmation surgeries now, and here's your training, and this is what we're going to do. And it actually would pretty much renew your faith in humanity, how well the nursing staff and the OR staff really took to that work and enjoyed it, and it's really thanks because of the patients. And oftentimes transgender communities or transgender patients oftentimes have to act as ambassadors and educate their providers somewhat, and there was a lot of that certainly at the beginning, but they did such a beautiful job. Our service became very popular to work on. So overall, I would say I was pleasantly surprised.
Now, that's great news to hear. You're never quite sure what you're going to face when you make an announcement like that, and what individuals are going to say when they're put in that situation. So
Yeah,
I'm happy to hear overall it was positive for you there.
yeah, absolutely. Yeah.
So you were in Indiana for 5 years?
It was about 8 years because I did training there as well. I did fellowship there, and then I left Indiana to go abroad. At the time, that was the best opportunity to travel to Belgium, and to get training was to travel abroad. So, yeah.
All right. Now, you've also recently announced plans to go into private practice, and you're just about ready to go live there in Miami. I am curious what led to that decision, and how has that been working separate from a larger organization, being out on your own?
Yeah. Well, so I think I began to realize a few years ago I'm a terrible employee. My work is my baby, and I don't take to people telling me how it should be done. So I'm one of these people who wants absolute control over the patient experience, and how soon the patient can get through to us. And being an employee, you simply don't have that ability. And there's certain limitations in what you can do, and even the larger healthcare systems will restrict what you can do on social media, that sort of thing. So it just really became a question of, I found that was a better fit than being an employee. I've never shied away from responsibility. So so far I'm absolutely loving it. Now, having said that, I managed to pick the most epically bad time to start a private practice at the beginning of a pandemic. So, but having said that, even still, our patients have been very patient with us, understanding. My office manager, who is also my sister, managed to get stranded in Ireland at the moment. So she's been doing a lot of her job virtually, and our patients have been so understanding and awesome. But having said that, we are ready to start surgeries again on the 29th. So I'm super excited about that.
Yeah, very exciting, and very excited for all those patients out there who are looking to get in and see you. So let's talk about some of those surgeries and some of the techniques you developed there. I know that you've actually developed quite a few new ideas in how top surgery for transmasculine individuals is completed. Right. And I am curious and wanted you to have a chance to talk a little bit about how your no drain technique differs from what else is available out there.
Yeah, absolutely. So when I started doing this work, I'm really focusing in on top surgery for the transmasculine patient. What I noticed was the most annoying part of recovery for patients were the drains. And so drains are basically little plastic tubes that are inserted into the body. And so when we remove the breast tissue, we're left with a space behind. And the old way of doing things, and the way it once upon a time I used to do it as well, was just to bring the skin together and put a tube in there to drain whatever fluid may form. So a few years ago, I remember looking at this problem saying, if only we could figure out some way to avoid the drains. And so the key was really what we call quilting stitches, which are just dissolvable stitches we put on the inside, and it closes down that dead space. And so the exciting thing, first of all, was we found we were able to safely avoid placing drains, which completely. We didn't have to place the drains, and that has some really nice spin-offs, just for patient comfort, really, in that their pain tends to be less. They're able to shower sooner after surgery. They can get out of the binder sooner after surgery. But then the really exciting thing was when we looked back at the data a few years later, we found that in fact it was safer. So not only were our patients not getting fluid collections, but our bleeding rate was less and our emergency reoperation rate was less than when drains were used. So it's kind of become a non-brainer. So our fancy word for that is masculoplasty. We're throwing around some ideas, and it was between that and mastectomy, and masculoplasty won out. So that name is stuck. But really, it's foremost a nice technique for patient comfort and then patient safety as well.
So speaking in very broad terms, when you go in with a patient who's looking for top surgery, what are your goals? Right. For you personally, when you're trying to masculinize a chest, what is the primary deliverable you're trying to achieve there?
Right, right. Well, so as a plastic surgeon, we're always trying to get inside the patient's mind and see what is inside their mind, and because it's our job to replicate that. And, just also as a side note, the patient top surgery, we don't have to necessarily masculinize. We don't have to make a typical masculine chest. And patients would oftentimes come to me with pictures, which is awesome. Plastic surgeons love to see pictures, because we can all be on the same page. So my first job when I speak to a patient is to ensure that we do want a masculine chest. If that is the case, then we talk about what are the dimensions for a typical masculine chest. And so in plastic surgery, it's such a fun field. We have actually studies done on hundreds of male or modeled male chests, if you like, and we know what the average dimensions, the average nipple size, the average place the nipple should be located. So we know what all these dimensions are. So typically I'll say to a patient, unless you tell me otherwise, we will stick with the dimensions for a natural masculine chest to fit your body. For example, the diameter of a nipple will be by the diameter of the patient's chest. So there's a lot of different things that go into it. And, one thing that's super important is that we look at pictures, before and after pictures, and, sort of figure out, so the patient can have a realistic expectation on it. One of my top tips for patients undergoing top surgery is find yourself in your surgeon's before pictures, and that'll give you a very good idea of what you look like after. So you want to have a good look through those pictures.
Definitely. And it's definitely something that I've done in my own journey where even if it's just before and afters of being on hormones, I look for people who look like me, right? And can kind of use that as the guide, right? So I can definitely see how that could be helpful for top surgery results. If you find someone who has a similar build or a similar before, you can sort of use that as a guide to what you could potentially expect out of it.
Yeah, absolutely.
So let's talk about some of those concerns, though. Oh, yeah, go ahead.
Yeah. Well, no, I just have to say, I did a heavy week of consults last week, and I'm always taken aback by, expectations, and patients tend to be, we'll talk about these details, and I'll, the patient will just say, I just want them gone. I just want a flat chest. Doesn't matter. So, as a group of patients to work with, I find most of my trans and non-binary patients so easy to work with, and I tend to be the perfectionist to say no, but we can, which is not the case in a lot of different plastic surgeries. So.
And that is something that comes up often, though. Sometimes people are so overwhelmed by just being in a surgeon's presence, they forget to ask those questions. But it is important to have that conversation and really think about what you want before you get in the room. And if you can, write it down, because you will forget in the moment. Those consults go so quick, and you'll just space on them in the moment. So write down the questions you have. And I am curious, what concerns do you hear from patients in consults? Do they what are the most common questions you get during those?
Yeah, well, so, my patients are fantastic because a lot of my patients have really done their research. And so that's another motivation of mine, is to get as much content out there on social media, because what you see me talking about on social media is pretty much what I sit in the office talking to patients about. It's just I'm having those conversations, except to a camera. So I found that has been super useful, because when I go to a doctor, I don't listen. I don't take it in. I'm sort of like, yeah, I'm going to read up about this later, and that's me as a doctor. I can't imagine for a non-medical person. So, first of all, I would say my patients are very well read, but obviously it depends on the surgery we're talking about. Probably one of the biggest questions with top surgery is, can I get keyhole, or what sort of procedure should I get? And if I can't get keyhole, why not? That tends to be another question that's really common.
So for those who do undergo top surgery, what does recovery look like for them? And I am curious how often you see people coming back for any revision work.
Yeah. Well, so I'll speak to my surgeries, which are the drain-free surgeries, right? Because it does make a big difference. And so right out of the operating room, what patients can expect, and I do know because we've studied our patients with masculoplasty very well, because obviously when you're doing something kind of new and you're looking around saying, well, how come I'm the only person doing this? You need to make sure you're doing the right thing. So we did, back at Indiana University, gather a lot of data on these patients. And so what we find is in the recovery room and in the first 2 days of surgery, which tend to be the most difficult, patients are rating their pain an average of 4 out of 10. Pain is a very personal thing. However, we now understand that it doesn't necessarily mean that a person's wimpy or something like that. Just people experience it differently after surgery. So then after that, in the next week or so, the patient is kind of like what we call a T-Rex. Their arms aren't coming into play much, but they're up and around and, feeding themselves, going to the bathroom, that sort of thing. If a patient flies in for surgery, I'm talking about the typical masculoplasty top surgery we do, where the nipples are removed completely and put back on again. The patient will need to have a special dressing on those nipples for the first about 3 or 4 days after surgery, and they can't leave the area really until that dressing is off, because I have to take it off. But once that dressing is off, they're able to travel back home. And then most patients will return to work or school in about 2 weeks, and then about 6 weeks after surgery, back to regular activities. So that will be the typical recovery from masculoplasty, which is my version of the double incision technique, which probably about 80 to 90% of patients who want to masculinize their chest, that's the procedure that we usually choose.
Now, I know we've spent quite a bit of time here talking about your top surgery options, but you actually do surgeries for trans feminine individuals as well.
Yeah, absolutely. And that represents about half of my practice. Unfortunately, there may be a little bit underrepresented on my social media because it's difficult, obviously, to post on platforms about vaginoplasty, and we can't really do the same before and
It's a little
afters,
harder
and
to share a before and after there.
yeah, yeah. And obviously patients, privacy will come into it, maybe a little bit more. But yeah, we certainly do the gamut of bottom surgeries, everything from orchiectomies to a zero depth procedure to typical penile and virgin vaginoplasty, and then more recently robotic peritoneal vaginoplasty as well.
All right, so we do have a lot of people watching here tonight. What's the best way for potential patients to get in touch with you?
The best way is always going to be our website. So that's www.gallagherplasticsurgery.com. And if you go to the contact us, that's usually the best way to find us. And we will respond to you. We tend to get back to you within about 24 hours. So.
Very good. One thing I definitely wanted to talk to you about here tonight is how you've embraced social media as part of your visibility supporting the trans community.
Yeah.
You're active on YouTube, Instagram, and most recently on TikTok. Why is it important for you to be visible online?
Yeah, well, so I think one of my biggest frustrations when I started working in this field was the amount of myth that surrounds gender affirmation surgery, and the availability of reliable online resources is pretty dismal. If the information's out there, it can be from an unreliable source, and misinformation is obviously a huge problem as well. But on top of that, you have to be able to have your patient understand you. Otherwise, what is the point? So, one study I was involved in, we looked at what we call readability. And, the National Institute of Health mandates that we should have the readability of medical information at about a fourth grader level or sixth grader level, and that's definitely not the case. So first of all, jargon, there's no point in that whatsoever. So I sort of feel like I had this evolution in my career. So the first half of my career, I was trying to take concepts and make them as difficult as possible, and putting data together and running logistic regression and all sorts of complicated things to put them in medical journals. And then I kind of realized, well, if this information isn't accessible to the vast majority of the population, what is the point? So it's really become a passion of mine over the past few years to simplify concepts. I'm a great believer, if you can't simplify your content or you can't simplify your material, you don't know your material well enough. That's a reflection on you. So really trying to simplify that material, make it understandable and make it accessible to the population who needs to understand it. And let me tell you, TikTok, those 15-second videos to try and explain a medical concept in 15 seconds, that's been a challenge, but it's awesome. We're constantly being pushed, and you just have to make that information accessible. And, we talk about the younger generation not having an attention span. Well, that's my problem then. I gotta make the information accessible to them. But it's incredibly rewarding then, because my patients, on the other hand, first of all, patients come to me, which is obviously fantastic, and then on the other hand, my patients tend to be really well educated, which is fabulous. So lots of benefits to social media.
Definitely. And I think that's such a amazing change here in just the last couple of years, where it seemed to be, not even that long ago, the only way you could get information about any surgeons providing surgery for trans patients was through somebody else who's already had surgery with them. So seeing you and other surgeons now making progress and making attempts to make their own practice visible and sharing knowledge out there directly from the source is so important when people are trying to make decisions about where to turn for surgical options.
Right. And, again, I have to say my patients have been wonderful. I'm always amazed, and other surgeons tend to be amazed at how willing they are to share their experience and let us record during surgery. And, this intensely private time, my patients have been absolutely fantastic about allowing us to pass on that information.
So I've got one more question for you before we get to our many, many viewer questions. So I want to give as much time as possible to that. But my last question for you is more of an introspective one. How do you want your legacy to be defined in how you've supported the transgender community?
Oh, wow. Well, so I always say the amount of gratitude the community has shown me is mortifying. It's embarrassing. I feel like I don't deserve it, because I always say this is the best job in the world I have. And it's such a privilege for me, for a patient, first of all, to trust me during this time and to, get that front row seat to what is often a very happy time. And like I said earlier, it's really my dream career, because there's always been this buzz around our office it's contagious. You leave work feeling pretty awesome about the world. And, time and time again, my faith in humanity has been renewed, by, parents of trans kids and, patients who've been through so much themselves, in order to transition and be their authentic selves. So, my patients tend to be extremely inspiring to me. So I think, the legacy, I'll be forever grateful to that. And so my legacy, if I can use my wits and, whatever intelligence or surgical skill I have to improve procedures, try and popularize that. In your career, you can touch thousands of patients, but if you can innovate a new procedure and popularize that and publish that, you can potentially touch many, many more patients. So I think, that will be a wonderful thing. And again, even just, to educate. I come from a family of teachers, and my sister is joining the practice as the office manager. She's actually manager. She was a school principal in Dubai, so I think that's kind of in my blood. And so to be able to pass on information in a very effective manner, I just get such a kick out of that. So most fulfilling career I can imagine myself having.
I think that's a beautiful answer. Thank you for answering that. And I do want to start getting over here to the viewer questions. So if you're watching live right now, you can still submit your questions through either YouTube, Facebook, or Twitch. But we're going to start tonight with the questions that were submitted earlier this week through Instagram. And our first question here is, do surgeons doing gender-confirming surgeries receive any clinical training regarding gender dysphoria?
Well, this is a great question. So, yes and no. Only recently have there been actual fellowships available. I think there's maybe 3, maybe 4 now in the country for this sort of work, and they're very limited with 3 or 4 positions available. So, whereas I came from Indiana University. I didn't have a fellowship there, but we had 20 plus trainee plastic surgeons who obviously worked with me and helped take care of patients. So oftentimes, like any other residency, residents and plastic surgeons tend to learn on the job and learn from the teachers such as myself. So I think the future is very bright. There will be a lot of those new plastic surgeons who are at least culturally competent, if not able to do top surgery, if not able to do bottom surgery as well. So, definitely things are improving all the time. And I think the younger generation get it. These medical students coming through, they will seek training specifically in gender affirmation surgery. Now, with regards to the psychological aspects and the gender dysphoria, it's not something that we are strangers to in plastic surgery. There's a lot of psychology in plastic surgery and any sort of modification of the experience, of the appearance. So therefore, it is something that the plastic surgeons are trained for overall. And then, of course, WPATH, the World Professional Association of Transgender Health, which I'm a member of, they have a lot of good training courses available for surgeons who specialize in this work.
All right, very good. Our next question, what type of questions should we ask surgeons during a consultation?
Okay, well, that's a great question. So I guess maybe we could look at this from the point of view at a consultation. There's you are qualifying your surgeon, and your surgeon is qualifying you to do this surgery, and making sure that you're both a good fit for each other. So as we alluded to earlier, oftentimes it can be difficult to find a surgeon in this field. So, a couple of questions that may be relevant would be, first of all, to understand if your surgeon is properly qualified to do your surgery, would be, are they board certified? So, and are they a board certified plastic surgeon or gynecologist or ENT surgeon or whatever the case may be? Because not all boards are created equally, and there's some boards that you can get through in about a year or so, as opposed to the plastic surgery training I did, it took 5 years of general surgery, 3 years of plastic surgery in addition. So first of all, just check out your surgeon's qualifications. Just make sure that they are board certified and that they are at the minimum qualified to do your surgery. And then my next question for that surgeon would be, in this day and age, for most plastic surgery procedures, you should have access to their before and after pictures. And so then the question would be, if not, why not? Because really photography for years now has been integrated into a part of our practice. And as I mentioned earlier, transgender non-binary patients tend to be very willing to share their experience and their pictures with other patients. So I think it's a fair question, to if you don't have your before and afters available, if not, why not? And during that visit with the surgeon, it's a lot of what makes a good fit between you and your surgeon is personality, and it's so important to be able to understand your surgeon as best as possible, because if you can't understand them now before the surgery, and then let's say you run into some difficulty after surgery, you're really not going to understand them then, and they're not going to be much used to
Very true.
used to you when they're reassuring you if you can't understand what they're trying to communicate to you. So those would be kind of some general questions I would ask.
You brought up a really good point, too. It's 2020. It's not 1990 anymore. If a surgeon doesn't have photographs to show you before surgery, that's a huge red flag. That's really unacceptable
Yeah,
in today's world to go into surgery
yeah,
blind, have no idea what to expect. But I
yeah,
still hear stories about surgeons out there who don't have evidence of their work, which
yeah,
that worries me. It does.
yeah. Hmm. Yeah.
All right, let's go on to our next question here. Any advice for people worrying about going too far with facial work and having a cartoonish outcome?
Oh, that's a great question. So facial feminization, let's say if we want to focus on that, it's maybe a misconception out there that you go to your surgeon, you're like, give me the facial feminization, just do the thing. And they're like, okay. And they do the facial feminization, which is a one size fits all. And that's really not the way modern facial feminization is, because it's a very personal thing. It's an individualized approach. And the patient obviously has a huge say in what their appearance is going to be. And the days of kind of reproducing, like an assembly line reproducing that sort of maybe Barbie doll kind of result, those days are long gone. So facial feminization surgery is certainly not a one size fits all procedure, and each step within the overall procedure needs to be carefully discussed with your surgeon. Your surgeon will guide you, because there are principles of facial harmony that definitely need to be taken into account. But one area probably we see patients and sometimes plastic surgeons going a little bit too far on is fillers and Botox. And you can actually do a lot of harm and disfigurement even from doing too much of those. And sometimes patients think a little bit is good, and they almost get this inability to see when they are getting a little bit cartoonish. So I tend to be known to be a little bit brutally honest and to cut patients off when I feel like they're beginning to distort their features, because you can actually, we've probably all seen it, you can do pretty irreversible damage. They seem like benign treatments, and they're fantastic sometimes for facial feminization, particularly lips, that sort of thing. But they're not necessarily benign procedures just because you're not going to sleep to have them.
Absolutely. All right, let's take a look at our next question here. Will masculoplasty scarring be shaped differently on a larger frame than a smaller one?
Oh, that's a great question. So, one thing, just to segue a little bit, one thing I see a lot in the United States is patients being turned down because of their body mass index or because of their weight, or, larger chests, larger patients. And that was something I never quite felt too strongly about. So, in my practice in Indiana, when I looked at my numbers, 55% of my patients had a BMI of over 30. And I sort of looked around, and it's one of these things, again, you're like, well, I'm the only one doing the heavier guys. I better look into this. So we looked at the data, and I actually published it last year in the Aesthetic Surgery Journal. And I found that we could do the larger BMI safely. Now, obviously, when a patient starts getting into what we call medically the obese categories, the risks are higher, and that's kind of to be expected. But when I see a patient, it's a risk benefit analysis. So doing nothing and allow a patient to live with this very large chest and bind uh, trying to bind a very large, and all the neck pain, shoulder pain, and other problems that comes along with that is not a benign thing. So therefore, depending on the patient's risk benefit analysis, I don't necessarily have a cutoff. But to get back to answer the question, it does make a difference, because obviously we can't plan the scars and put them wherever we want, because essentially we're removing breast tissue, so they need to be planned and put where the breast tissue is. We can try and design them to be hidden underneath the pec muscles as much as possible, to give the most natural aesthetic, but we do need to follow the breast tissue. So overall, in larger chests, sometimes what we'll see is the scars can kind of tilt down towards the sides as we chase out that tissue.
All right, next question here is related. How long does top surgery take? Oh, all right. Just waiting for the sound to come back here for Dr. Gallagher.
Yeah, I'm back, I think. Yeah, sorry.
Okay, so we're
Can you
good
hear me?
there. All right. Yep, you're good. So the next question was, how long does top surgery take?
Top surgery typically takes me between 90 minutes and 2 hours, but again, it depends on the size of the patient. So the more tissue we have to remove, the more time it takes.
All right. And after surgery, how much energy will I have after top surgery? And how well will I be able to get around after?
Yeah. So in the first about week or two after surgery, we see, I think I mentioned that earlier, our patients sort of do the T-Rex thing. Their arms aren't coming into play too much, but they're able to get around. They can feed themselves. They can eat just fine. They can go to the bathroom by themselves. And gradually over the next few weeks, the arms will kind of come back into play. But one thing it's a little bit counterintuitive is we oftentimes see our younger patients kind of feel like they've gotten their ass kicked maybe a little bit more because it's their first time they've had surgery. So it's very typical for them to get tired fast. That's a very typical phenomenon. So.
All right. So our next question here, going from our transmasculine patients to transfeminine, can trans women with intact prostates still develop BPH as they get older?
That's a great question. So, for viewers who may not be aware, typically with vaginoplasty, we do leave the prostate behind. Now, why do we do that? Removing a prostate is a pretty invasive procedure, and it has risks of urinary incontinence and sexual dysfunction as well. So the prostate stays behind, typically minding its own business, and it oftentimes is quite small in the absence of testosterone. So whereas theoretically it is possible to get BPH, which is benign prostatic hypertrophy, it is potentially possible to get that. We rarely see it because what oftentimes causes that is higher testosterone levels. So if we don't have those high testosterone levels, it's unlikely to
All right. And again, another transfeminine question here. What degree of hair removal is needed prior to vaginoplasty? All right. She's putting her headphones back in here. It's going to take just a second to get
There,
her
I'm back.
back. Okay, there we go. So
Yeah,
the
sorry
next
about that.
question here
Yeah.
was about hair
Yeah.
removal.
Hair
Uh,
removal. Okay. So this is an area I'm maybe pretty controversial in. So when I began doing vaginoplasties, hair removal, my mentors insisted on hair removal before surgery. But I had a few patients who I think it maybe snuck under the wire, and patients can be so desperate to get their surgery who may not have been very honest. And when we went to the operating room, sure enough, when we took the graft off and looked at the other side of it, there were a lot of hair follicles there. So we would destroy those hair follicles, and those patients actually did okay. So there's only really one study, unless there's a more recent one, there's one study done on this looking at 250 patients. And what they found was 7% of those patients had issues with hair growth after surgery. But the interesting thing was that it was independent of whether or not they'd undergone pre-operative hair removal. So according to that study, at least, it didn't seem to matter whether or not they've had their hair removal. So for that reason, one thing about hair removal is it's painful, it's difficult to access, it's expensive, it takes about 6 months to do it. And for some patients, it's difficult to find, if you're in rural Missouri or something like that, it's going to be very difficult to find an affirming provider. And it can be very dysphoric, sitting there having your genitals exposed as you undergo the procedure. So there's electrolysis or there's laser hair removal. So in order to insist a patient has this surgery, I felt that we really need a good reason to do that. And what I was finding, certainly in those patients who came along afterwards and confessed that, I didn't do any hair removal, they were doing okay. So I stopped insisting on it about 100 patients ago. And what we found was, at least not that they've reported to me, those patients haven't had hair problems, hair growth problems. And the other aspect of that, the only patient who has ever complained of hair problems went through extensive electrolysis prior to her surgery. So laser hair removal, hair reduction, it's more hair reduction. And so for all of those reasons, what I like to do in the operating room is spend a decent amount of time removing hair follicles. And how we do that is we cauterize them under direct visualization. And we do the best we can during the surgery to avoid it. And so far, touch wood, I'm going to be watching those 100 or so patients very carefully, but they haven't reported to me yet any issues. So.
No, that's fantastic news. And as someone who had to do the hair removal process before I had surgery, if there was a way to avoid that, I would have much preferred that option.
Yeah, I'm definitely not the first to do that. Other bottom surgeons who have been very busy and have been doing this longer than I have offered too. So I can't claim to be the first one there, but so far so good.
All right. Our next question here, the dreaded waitlist question. How long is your wait list on average?
Okay, well, that's a great question. So that's another reason I went into private practice, because I felt like, that was a huge barrier for patients. And, I'm a workaholic. I would operate as much as I could physically be able to do. So I love operating, and I feel like a good surgeon is a busy surgeon, and it just makes me better at my craft. So that was a big reason I went into private practice, because I wanted to streamline things and make things as efficient as possible. So, between myself and my sister NASA, who's an MBA, and she's kind of the brains of the family, we're kind of coming up with, she's already innovating a lot with ways to, try and fast track patients through the system. So our wait list is not too bad. We're kind of in weird times. It's usually a few months for surgery, but we're in a weird time right now with COVID, because a lot of patients unfortunately lost their job and lost their insurance, and for that reason have pushed back their procedures. So right now with us, it's not too bad.
All right. So that wraps up the Instagram questions we had there. I do want to get over to the YouTube questions. So let's go ahead and start those here, Stephen. First question from the live chat here tonight. Do trans men have sensation in their nipples after top surgery?
Yeah. So, again, like we talked about, the most common way in the United States right now that most transmasculine and non-binary patients will have their top surgery is a double incision with a free nipple graft, or my version of that is masculoplasty. And in that procedure, we're taking off the nipple completely and planting it back on again. And so I was taught in medical school that no, there's no sensation. You will not get sensation. But then, of course, my patients, again, educating me as I was further into my career, said, no, I got sensation back. And so we do see it takes a long time, but the vast majority of patients will get their sensation back. And there's a great study out of Germany from a few years ago answering this question. They surveyed their patients and they asked them about this. And what they found was 80% of those patients had what they described as good sensation. Now, again, what does good sensation mean? We're not too sure. And, a patient needs to be aware that, if their nipples are erogenous and it's important to their sexuality, that it's probably not going to be the same as it was before. But particularly if a patient has larger breasts, it's very difficult to masculinize the chest and get that nice flat look they're going for and guarantee that they're going to get their sensation back. And really, keyhole, buttonhole, none of the different techniques described guarantee that the patient will still have their sensation. So it's definitely one of those things that it's worth taking into account.
All right, great answer. All right, our next question here. Can zero depth be converted to full vaginoplasty at a later time?
Okay, well, so I always want patients to understand before zero depth that you don't want to ever be signing up for two surgeries if you don't have to. And the other thing is, we're getting rid of tissue that we would typically use to create a new vagina. So, as a surgeon, I understand things can go wrong in surgery. So, never plan to get your zero depth and think, later on I'll get my vagina put in. Like really try and do a one-stop procedure because you never know. You don't know what the future holds for you, and you don't want to have that regret of not getting what was the correct surgery for you. So that would be the first disclaimer. But theoretically, it's absolutely possible to convert a zero depth procedure into a vaginoplasty. The one thing we're going to be left with is, where do we get our spare parts to line the new vagina? Now, the good thing is, in the United States, most of us have some extra skin hanging around, and most of us have maybe a little pooch and a little belly, so we could almost do like a mini kind of tummy tuck and take skin from there. Um, it's one of the things as a plastic surgeon I used to love to do, particularly in reconstructive cases, was find nice places to take skin when we needed skin for skin graft or whatever. And this kind of puts us in that situation. So it's definitely been a situation I've been in plenty of times before, looking for spare parts to line something. And so it's definitely possible to do, but just make sure you're signing up for the right surgery in the first place.
Yeah, we have a related question here too, talking about zero depth. Somebody was wondering if weight is going to be an issue to getting bottom surgery, especially the zero depth option. And do you ever, or have you ever had any patients that have regretted zero depth?
Okay, so as we discussed earlier, I tend to be pretty lax about weight requirements overall in my practice, and I want to make sure patients have access to surgery if they need it. However, it is very difficult to do a vaginoplasty in a patient whose BMI is over 30. So that's one of the ones I have an absolute limit. I won't do a vaginoplasty in a patient that's over 32 because safety begins to become compromised. And the reason is, when we create a vaginal canal, and I know that's not what this question is about, but I'm being long-winded. But when we create a vaginal canal, we are in a very tight pelvic space, and there's some really important things down there, such as the rectum and the bladder, and that we need to be able to fully visualize and protect. And I just find that once that BMI gets over 32, my visualization's a little bit limited, so I won't do it over 32. Now, zero depth is different, however, because we're eliminating that step. So if we're talking about patients with BMIs of higher than 32, some of our surgical risks will be increased, such as infection, such as wound dehiscence, and the anesthesia risks. But I kind of take every patient on an individual basis. And then, if all that fails, an orchiectomy for a patient with a larger BMI, until they're at the right BMI, that can be a very affirming procedure in the interim. So, which is technically a lot easier to do than zero depth or vaginoplasty.
Mm-hmm. All right. Our next question here, what's the youngest age a trans woman can get bottom surgery? And I suppose if we're going to answer that question, we should also talk about what's the youngest age that someone can get top surgery as well.
Yeah, yeah. Okay, well, so most surgeons in the country will take their guidelines for who should have surgery from what we call the World Professional Association, the WPAT standards of care. So we're now in version 7, and version 7 says you have to be of the age of consent in that country. So when insurance policies were figuring out who they were going to, insurance companies were figuring out who they were going to allow to have surgery and cover surgery for, most of the insurance companies pulled their policies from the standards of care. So it's written in there in black and white that you cannot have surgery under the age of 18. And it's a little bit difficult to argue against that, because, the insurance companies say, well, your professional body recommends that. So certainly we do need to do more work, and the next version of standards of care will be very interesting to see what's being said, because we all know that not doing surgery isn't harmless. gender dysphoria is a serious medical condition, and it's not a very easy thing to just say, nope, not for you, continue to suffer from your gender dysphoria. You really need a good reason why. And so, for that reason, most surgeons in the United States will offer top surgery at younger ages, typically to non binary and transmasculine patients. And we do it in discussion and support with the parents and obviously the mental health professionals. And how I approach it is it's a risk benefit analysis. It depends on that individual, and not all 15-year-olds are alike, not all 18-year-olds are alike, but we want to make sure that we're doing more good than harm to that patient. So the youngest, probably the most gender affirming surgeons like myself will offer top surgery to patients would be about 14 or 15. 15 actually would be the more common age. But for bottom surgery, these are more complex surgeries. It's very difficult to fund them without insurance. And so for that reason, we're usually stuck with our 18 before we can do bottom surgery.
And I know I'm speaking in very general terms here. I definitely don't want to leave out non-binary individuals in the conversation. I am saying transmasculine for top and transfeminine for some of the bottom surgeries out there, but there are non-binary individuals who are seeking these procedures as well. And I definitely wanted to make sure that we're recognizing that here on the show.
Yeah, and it's probably represents about 20 to 30% of my patients. So yeah.
Oh wow! See, now that's an interesting stat. That's one I haven't heard before.
Yeah.
All right. Our next question from YouTube here. Do you do the peritoneal pull-through vaginoplasty? And if you do, is dilation required with it?
Okay, great question. So to give an overview very quickly, what is the peritoneum? I wouldn't expect a non-medical person to know what the peritoneum is. So the peritoneum is the inner lining of the abdominal cavity. So just like your skin on the outside of the body, you have a skin on the inside, and it's soft, kind of filmy, shiny material. And so in the realms of what we call vaginal agenesis, that's when 1 in 5,000 non-transgender female patients are born without a vagina. This was what we call the Davidoff procedure, where they would make a new vagina basically from the peritoneum, because it was a lot like the lining of a vagina. So for this reason, there was, raised the question, could we use it in the trans feminine patient? Because maybe we could get rid of the painful requirements that regular penile inversion vaginoplasty has, which is always going to be lined with skin, and that's the requirements for dilation and the lack of lubrication. So that's the reason surgeons and patients alike became interested in this procedure. And so one of the earlier papers published on it was out of NYU. Dr. Rachel Blubon-Langer and Dr. Zhao there put together a great series where they were using the peritoneum to cap their neovaginas and make it deeper. But what they found was that you did absolutely still need to dilate. At Indiana University, along with the urology team there, we were able to use more of the peritoneum to line more of the depth of the vagina. So basically, we didn't use any of the scrotal skin at all. We were able to get rid of that, and the vast majority of the vagina was lined with the peritoneum. So those patients did well. However, we did have one patient who, unfortunately, for personal reasons, wasn't able to dilate afterwards, and she did lose depth. So it seems to be that right now this is a new procedure. It's not widely available around the country, and it's the jury's still out. We don't know if it seems they definitely still need to dilate, unfortunately, afterwards. And it's a longer surgery, and it does come with maybe slightly higher risk, because we have to go into the belly and put scars on the belly to do it. So that's peritoneal vaginoplasty.
All right, we are just about at our hour here, so I want to have one more question for you. I do want to say, though, because we've had a lot of questions in the chat here tonight, as a reminder, Dr. Gallagher is active on social media. She does answer questions. So if we weren't able to get to your questions tonight, I do want to definitely recommend people follow Dr. Gallagher on Instagram, TikTok, YouTube, or other social media platforms. You do a fantastic job of answering questions there, so I definitely want to make sure people are aware of your presence.
Awesome. Thank you.
And let's go ahead and get to the last question here. We just chose it at random. Vaginoplasty question, do you do one stage or two stage?
Okay, so the most commonly used vaginoplasty technique here in the United States would be what is referred to as a two-stage technique, because there's certain things you can't accomplish at one surgery. And I don't really know of any surgeons who are sort of doing it all or sort of claiming to do it all. But typically, with the penile inversion vaginoplasty, or even with the peritoneal vaginoplasty, we're not able to make the outer labia majora meet in the middle. So that step is usually done as a secondary labiaplasty down the line. Now, having said that, a lot of my patients, probably up to 50% or more of them, kind of were like, no, I'm good. I don't need, looks fine, and didn't go for the second stage of the surgery because it's totally elective. You can do it at any time. You have to wait a few months, in my opinion, for swelling to settle down, but you don't necessarily have to do it. So yeah, I do the two stage. I'm not really aware of any technique that allows you to bring the labia majora, just because you're risking the blood supply. There may be surgeons who are risking it somehow, but it's not in my training, and I don't incorporate that as the first stage. But the good thing to know is labiaplasty is a very quick nip tuck. It's a very easy procedure, and is nothing like the original vaginoplasty when it comes to invasiveness. It's usually an outpatient procedure. So
good. All right. Well, that was a barrage of questions. You did very well. Didn't even take a sip of water at the full hour there. I just want to ask you to hold on for just a moment here. We'll say goodbye in just a moment, but I do want to remind everyone who's watching tonight, if you're not already following us on YouTube, please hit that subscribe button. You'll be notified whenever we go live on our Thursday night shows. We're Trans IRL on YouTube, and we're also over on Facebook at Trans IRL Show. You can catch our updates there, and you'll get notifications in our stories about who our guests are for our next show. On Instagram, we're Trans IRL, and Instagram does give you the opportunity to submit your questions before showtime, so you get first dibs with our guests. And we are also on Twitch now. So if you haven't checked us out over there, you can watch us on Twitch, and then immediately following, you can hang around for the Transvengers who start their show in just a little bit here. But with that, let's bring everyone on here. Dr. Gallagher, thank you so much for your time here tonight. Absolutely wonderful conversation. Appreciate how open you were with us. And I think we answered just so many questions, which I think is so important, getting that knowledge out there.
Yeah, well, thank you so much. That absolutely flew. People who know me know I could just talk about this. I could have gone on all night. So thank you so much for allowing me to speak.
Absolutely. Thank you again. And Stephen, thank you for running the show. And for all of our viewers out there, thank you so much for joining us here again tonight. We'll get our next episode information up on Instagram when we have our next guest lined up. From all of us here, have a wonderful night.